Bismillahirrahmanirrahim. Assalamu alaikum. Welcome into the fourth episode of our workshop on management of diabetes mellitus in Ramadan fasting. Today we shall discuss the type 1 diabetes mellitus patients. We shall discuss how to advise our adolescents and adult patients who are having type 1 diabetes mellitus and are using insulin, whether they should fast or not, and if they should fast, what change should be done in their insulin dosages, the timings, and types of insulins. So we shall discuss all these aspects in today's vlog. We are in the fourth episode of our workshop, the Ramadan and Diabetes. Yesterday, we learned that guidance on the management of diabetes must be provided prior to Ramadan. This is very important, that we guide our patients prior to Ramadan, whether they can have fast or not, and if they want to fast and they are eligible to fast, what precautions they must have. A pre-Ramadan assessment needs to take place, ideally 6 to 8 weeks before the start of Ramadan. The healthcare professionals needs to obtain a detailed medical history and perform a risk assessment. This risk assessment forms the basis of all recommendations thereafter. These include advice on whether fasting is safe, strategies for dose modifications, and treatment regime adjustments, the provision of Ramadan-focused education and nutrition advice. Following this, individuals that decide to fast will need to adhere to guidance on the management of their diabetes during Ramadan fasting, including changes to glycemia monitoring schedules and dosing adjustments of medications. Finally, after Ramadan ends, it is advised that a post-Ramadan follow-up is performed. A follow-up after Ramadan helps healthcare professionals obtain crucial information about the individual's successes and challenges during Ramadan and ensures that Ramadan fasting in the following year can be more successful. This is the pre-Ramadan assessment status. Structured education for all individuals to include risk quantification. We should know what is the risk of that patient. The role of self-monitoring of blood glucose. What is that role? We should need to educate them that what is the role of SMBG, when to break the fast. We should guide them, we should inform them, we should educate them that when they will break the fast, when to exercise, what timing, what type of exercise, fluids and meal planning, what should be about, how they should care about their fluids and meal planning, and of course the medication adjustment during fasting. So the medical education at the pre-Ramadan education has these 6 essential components. Then all individuals seeking to fast should attend a pre-Ramadan visit 6 to 8 weeks before Ramadan. This is important. Then when you do the assessment, then another step is to stratify risk and develop an individualized management plan. So this will need detailed medical history, aspects of diabetes and ability to self-manage, the presence of comorbidities, the individual's prior experience in managing diabetes during Ramadan fasting last year, how they performed, the individual's ability to self-manage diabetes, and other aspects increasing the risk of fasting. We have explained all the risk stratification in the previous vlog, so all these are now practically executed. A risk stratification, you divide into whether the patient belongs to low risk, moderate risk, and high risk. Then after this stratification, then during Ramadan, you advise them on frequency of the self-monitoring blood glucose, and it needs to be guided by risk stratification and visualized. If the patient is in high risk, moderate risk, low risk, you advise them accordingly. Then all individuals should break the fast if blood glucose is less than 70, or and they should recheck within 1 hour if blood glucose is 70 to 90. If the blood glucose is more than 300, or symptoms of hypoglycemia or acute illness occurs. So you guide them that if these scenarios happens, if these happens, they should break their fast. And after when the Ramadan is over, then the post-Ramadan assessment is very important. So, as said in the intro, today we are discussing the insulin regimes and blood glucose monitoring among patients with type 1 diabetes. And we start from the adolescents. The most widely used insulin regime in adolescents are basal bolus regimes, that you give the basal as well as the bolus regimes. Then continuous subcutaneous insulin infusion with or without sensors. This is not common here in Pakistan. Only in selected centers or a group of people they are using it. Then conventional twice daily in pH or regular short-acting human insulin, and pre-mixed insulins. So these are the different types of insulins, are the most widely insulin regimes which are prescribed in adolescent here in Pakistan. Basal bolus, one basal and two or three bolus prior to breakfast, prior to lunch, prior to dinner, are continuous, very rarely, are conventional, twice daily. The combination of the intermediate acting and short acting are pre-mixed insulin. For adolescents using non-continuous insulin infusion therapies for type 1 diabetes mellitus management, the following is recommended. What are the recommendations? Basal bolus regime is preferred over conventional twice daily regimes. So you give one basal dose and then two boluses doses. Pre-mixed insulin regimes do not provide the necessary flexibility for fasting due to the rigidity in nutrition that is often required with these therapies. So these are not that ideal. The self-monitoring of blood glucose must be performed regularly throughout the fasting hours, and whenever there are feelings of being unwell. If accessible and available, the continuous glucose monitoring are the preferred methods for monitoring of blood glucose levels, but by and large, the recommendations are that the basal bolus regimes as well as self-monitoring of blood glucose. We have discussed this self-monitoring of blood glucose in the last vlog, so you can go there and you can refresh your understanding from that vlog. First, the basal insulin with good glycemic control when HbA1c is less than 7.5, reduce dose by 20 to 30% and take the basal dose at iftar or midnight. When there's poor glycemic control, HbA1c is more than 7.5, keep same doses and follow up, take the dose at iftar or midnight. So when it's a good glycemic control, you reduce the dose by 20 to 30%, but if it's a poor glycemic control more than 7.5, then you keep the same dose. The prandial insulins, patients on, you put them on the when they are on the ICR or ICF correction, you continue the same for iftar and so on. And patients not on fixed doses, then you do not change it iftar, but reduce the suhoor dose by 20 to 30%. So then in the suhoor dose, you reduce 20 to 30% and you don't change the iftar dose. An individualized approach is essential for treatment adjustments according to patients' self-monitoring blood glucose or continuous glucose monitoring data. For better postprandial control, it is advised to take the bolus 20 minutes prior to iftar to account for high fat and high protein meals, which most of the times we people take. High blood glucose values may require extra correction doses based on insulin sensitivity ratio and target blood glucose. Correction doses must not be given more frequently than every 3 hours to avoid insulin staking and hypoglycemia. This is a very important point. The basal bolus multi-dose injections with analog insulin. What about that? In the basal insulin, what you do, 30 to 40% reduction in dose and to be taken at iftar. Rapid analog insulin, what you do with that, dose at suhoor to be reduced by 30 to 50%. And pre-lunch dose to be skipped because no other patient is fasting. And of course, the dose around iftar to be adjusted based on the 2-hour post-iftar glucose reading. So you adjust that. And for that, you can use the 7-point glucose monitoring, and I have discussed that in the previous vlog. Basal bolus with conventional insulin. What about that? The in-patch insulin, the usual pre-Ramadan morning dose to be taken in the evening during Ramadan. So you do this one change. 50% of the pre-Ramadan dose to be taken at the suhoor. So you reduce the suhoor dose by 50%, and whatever he was taking the morning dose, you change that to the evening dose. Then regular insulin, what about that? In this combination, dose at evening meal remains unchanged, and suhoor dose to be 50% reduced of the pre-Ramadan evening dose. So you change the timings and you reduce the suhoor dose, which he was taking in the dinner time. Afternoon dose to be skipped. This is understandable. The 7-point blood glucose monitoring 2 to 3 suggested readings throughout the day. These are very important. Pre-mixed analogs are conventional. Those who are using this and they want to fast, shift the usual pre-Ramadan morning dose to iftar, 50% of the pre-Ramadan evening dose at the suhoor. So you change the timings. The morning dose goes to the evening and the same, and the evening dose come to the morning and you make it 50%. At least 2 to 3 daily readings and whenever any hypoglycemic symptoms develop. Type 2 diabetes, this was about the type 1 diabetes. Ramadan fasting among people with type 2 diabetes can present many challenges. The key concerns relate to uncontrolled blood glucose levels that can lead to hyperglycemia and or hypoglycemia. The appropriate and effective blood glucose monitoring and medical management of type 2 diabetes is crucial to ensure safety during Ramadan. So we shall discuss this type 2 diabetes in our coming tomorrow's vlog. So till then, take care, and we meet tomorrow in the discussion of the type 2 diabetes mellitus in the Ramadan fasting. Khuda Hafiz.